that looks great. Thanks, Dr. Huang. All right, we'll get started. So we have plenty of time. I know some more people will be joining, but welcome to Project Echo Geriatrics. For those of you who live your life like me on the academic year, this is our last session of the academic year, although we'll keep going in July, but I always like to mark the end of the academic year because there are a lot of transitions that happen. Some people have recently graduated. If you're a student, some residents have already graduated from residency and some are about to. Do we have any soon to be or recent graduates on here? You can raise your virtual hand or your actual hand if I can see you on camera. Well, congrats if you're not able to raise your hand. And for all of you, congratulations on making it through another academic year and for all the growth you've done this year. And we're all excited for July because it brings new beginnings for us. Our speaker today is absolutely fantastic, and I'll tell you about him in a moment. We will run this session like we usually do. We will have a didactic that'll be about 15-ish minutes with some time for questions, and then we'll go into a case discussion with all of you and with our interprofessional geriatrics expert panel. So thank you for joining on this June day. It's kind of overcast in Seattle. Don't know how it is where all of you are, but either way, thanks for joining in June. Dr. Joe Huang is our speaker today. He's a geriatrician and internist based at Harborview. I've known Joe for a while. He is a really fantastic teacher, and he practices in our senior care clinic and is one of the main providers in our Healthy Bones Clinic at Harborview Medical Center. He has a lot of expertise in osteoporosis, and he's going to share that with us today. So thank you, Dr. Huang, for taking the time to speak with us today.
Thank you, Kate, for that introduction. I'm not sure why my camera is not working, but talking to you today about anti-fracture treatment for osteoporosis. So why is this topic important? Well, in the United States, about 2 million fractures occur per year, and this is based on pretty old data that has not been updated. With the aging of the population, the number of hip fractures is expected to increase by 70% by 2040. Within 1 year of a hip fracture, all-cause mortality is as high as 30%. And surprisingly, within 1 year of hip fracture, 10 to 50% of patients do not receive any anti-fracture treatment. So we'll talk about all of the FDA-approved medications available for prevention of fractures and osteoporosis. The first class of medication are the bisphosphonates, which consists of alendronate, risedronate, abandronate, and zoledronic acid. These are anti-resorptive drugs. They, in total, lower the risk of hip and vertebral fractures by 20 to 70% after 3 years of treatment. It's important to note that abandronate, which is the monthly dosing, only prevents vertebral fractures. In postmenopausal women with osteopenia and high risk of fracture by fracs, so that their 10-year risk of having a major osteoporotic fracture is greater than 20%, or their risk of hip fracture is greater than 3%, the use of IV-ZA every 18 months for 4 doses prevents fractures. The number needed to treat is 15, which in comparison to something like statins for prevention of cardiovascular events, the number needed to treat is like in the 30s. Important side effects for bisphosphonates is renal dysfunction. They're contraindicated in patients with their creatinine clearance of less than 30 to 35. Hypocalcemia, which needs to be corrected before treatment, and esophagitis, This is why they need to remain upright for 30 minutes. It can cause pill-induced esophagitis. Rarely osteonecrosis of the jaw and atypical femur fractures. Infusion reactions can occur with IV zoledronic acid, which tend to get better with subsequent infusions. We can use these drugs for up to 10 years for oral bisphosphonates and 6 years for IV ZA. And in patients at low fracture risk, we can use a drug holiday for up to 5 years, typically after 5 years of treatment with an oral bisphosphonate and 3 years of IV ZA. Another anti-resorptive drug, which is more potent, is denosumab or Prolia. The indications are for men and women with glucocorticoid-induced osteoporosis, men on androgen deprivation therapy for prostate cancer, and women who have breast cancer on aromatase inhibitors who are at high fracture risk, or those who are at high fracture risk who are intolerant of other therapies. Prolia is able to reduce the risk of vertebral fractures by 70% and hip fractures by 40% at 3 years, with continued risk reduction up to 7 years. It's a subcutaneous injection every 6 months administered by a healthcare provider. The side effects are similar to bisphosphonates, but hypersensitivity reactions can also occur, hence the need for provider administration. The duration of treatment is up to 10 years. In contrast to bisphosphonates, this drug is not appropriate for drug holidays due to increased risk of multiple vertebral fractures, particularly in patients with a history of vertebral fractures. So anabolic drug is romosozumab or Evenity. We use it for postmenopausal women at high risk of fracture or those with poor response or intolerance to other drugs. It lowers the risk of vertebral fractures by 70% and clinical fractures by 40% at 1 year. It's much more effective compared to alendronate, 50% fewer vertebral fractures and 40% fewer hip fractures at 1 year. It's a monthly sub-Q injection administered by a healthcare provider for 12 months. Important side effects is that it may increase the risk of stroke, cardiovascular events, and death. It has a box warning for that. Also, hypersensitivity reactions. There are rare reports of osteonecrosis to the jaw and atypical femur fracture. It does have some low anti-resorptive capacity. It's contraindicated in those with a stroke or cardiovascular event in the past year. Another class of anabolic drugs are the PTH analogs, such as teriparatide and baloparatide. It's used for men and postmenopausal women with osteoporosis and high risk of fracture, and those with steroid-induced osteoporosis, those taking a prednisone equivalent of greater than 5 milligrams per day. These drugs lower vertebral fractures by 75% and non-vertebral fractures by 40%. These are daily sub-Q injections at home for at least 2 years. Important side effects can cause orthostatic hypotension. We like to have patients do the first dose in clinic as a result of that. Leg cramps, nausea, and it can also cause transient hypercalcemia. So we want to be cautious or avoid this in patients who have active or recent kidney stones or hypercalcemic disorders. Contraindications, so patients with a history of malignancies, prior or active, those at increased risk of osteosarcoma, such as Paget's disease, or those who have prior radiation therapy to the skeleton. So estrogen and hormonal therapy, it's typically a second-line therapy for women early in postmenopause who are intolerant of drugs and at low risk of having a venous thromboembolism. So the Women's Health Initiative study showed that the oral hormonal therapy reduced clinical vertebral fracture and hip fractures by 35%. Raloxifene is a selective estrogen receptor modulator. It has only been shown to prevent vertebral fractures. With this class of medication, there is rapid bone loss with discontinuation. That needs to be followed up with anti-resorptive treatment, typically. Main side effects, increased risk of MI, stroke, and VTE. Reanalysis of that women health study data showed that MI and stroke was not increased for women starting within 10 years of menopause. And calcitonin. So it's also second-line therapy for women who are at least 5 years from menopause. It prevents vertebral fractures by 30% over 5 years. We more commonly use it for pain relief in patients who have vertebral fractures, and it does help with early mobilization for these patients on the order of weeks compared to Tylenol. It's a nasal spray or sub-Q injection daily. Side effects mainly are rhinitis, epistaxis, allergic reactions, and there is an increased risk of cancer with long-term use, and it's banned from Europe and Canada for that reason. So considerations, so if possible, use only drugs that prevent both vertebral and non-vertebral fractures. In patients with high fracture risk, we want to treat with the anabolic agent initially, followed by an anti-resorptive. There's data that suggests that treatment with an anti-resorptive first, then an anabolic can actually lead to decreased effect of the anabolic or even bone loss. And lastly, osteoporosis is a silent disease until someone fractures, and therefore adherence to treatment is a serious problem. Only less than half of patients are taking their medications at 1 year. So it's important to have careful discussion and routine monitoring with patients when they're on these drugs to promote adherence and ultimately prevent fractures. That's what I have for today.
Thank you so much, Joe. We have time for some questions or comments if anyone has them. While people are thinking of their questions, I was wondering, since you take care of so many people with osteoporosis, Joe, how do you approach the discussion with people? You know, the anabolic agents like romosozumab and teriparatide that help build up the bone, you know, before anti-resorptive treatment do require interaction with the healthcare system or a daily sub-Q injection. Like, how do you approach that discussion with folks?
In terms of like the frequency.
Yeah, like,
Yeah.
you know, how do you phrase it so that people might be open to going to a clinic once a month for something, you know, especially since osteoporosis doesn't have symptoms until you fracture.
Yeah, yeah. I really spend a lot of time helping them understand, you know, what osteoporosis is, that their osteoporosis is actually, you know, severe or very severe. And it's something that's important to be aggressive with in terms of treatment, just like any their other medical conditions. And I think it helps, like, if I'm not seeing them, like, if I'm seeing outside of Healthy Bones, like, I will prioritize, like, you know, in terms of, like, you know, during the visit, like, I'll talk about their osteoporosis first, you know, if they don't have any other, like, acute, like, urgent concerns, like, you know, and, like, in terms of, like, the topics that are addressed from their comorbidities, like, so they understand, like, I'm, you know, making this I'm prioritizing this. And so they understand that it's important. You know, it's not like the last thing I'll talk about after I talk about like their diabetes or their, you know, heart failure, et cetera. You know, it'll be like the first, because, you know, ultimately it's for most of my patients, the thing that will threaten their independence and their functional status, you know. So I think that helps. I think it helps showing them like, you know, like the pictures of osteoporosis, you know, the bone, normal bone versus osteoporotic bone, like those type of images, so they can see, wow, okay, what's really going on inside. I might not be able to feel it, but this is what's really happening, you know? So I think that's really helped to get that buy-in from patients. That, you know, you know, I do recognize the burden of transportation every month, et cetera. But I feel like that's really important to get them to buy into that type of treatment paradigm.
Absolutely. Thank you. That's really, really helpful, the way you approach it and the way you described it. Ruru is wondering if there's an optimal duration for calcitonin. And I think you're talking about when it's used for vertebral fractures or compression fractures. Do you happen to know this, Joe?
So I typically don't use it beyond 2 weeks. Um, I think that's the effects of that, the pain relieving effects is really I think dissipates after 2 weeks. I think you get the most pain reduction in the first 2 weeks. So you get like pretty rapid tachyphylaxis with that medication. So so yeah, I limit it to 2 weeks in my practice.
You're right, Ruru. Thanks, Joe. Yeah, I've seen it. We end up using it a lot at Harborview since we take care of a lot of folks with fractures on the trauma service. And yeah, I have frequently seen 4 to 6 weeks for that pain relief. And it does seem to, it does seem to be helpful in reducing need for other analgesics. And I think you're still in that safe window as long as you're not going much beyond 4 or 6 weeks.
Mm.
Dr. Braun is asking about when you recommend repeating a DEXA and, what's the role of the use of N-telepeptide?
All right, great question. So, so the DEXA schedule, I would say in general for patients who are at moderate risk of fracture, I typically do every 2 years. Okay. I think within the first year of treatment, regardless of what you're using to treat, I will get a DEXA scan after the first year of a treatment, and then every 2 years that are after. And those on a drug holiday as well during the drug holiday. If they're of moderate fracture risk, low moderate, I think every 2 years. For patients who have high fracture risk, so on steroids, multiple risk factors for fracture, then I feel like every year is appropriate for those patients. And then in terms of bone turnover markers, so that could be a whole talk on its own, but I typically, I think for patients, I don't, for the routine patient, I don't get them. They have to be done fasting in the morning, so that's a barrier for a lot of my patients, like to be right at the early morning fasting to get that study. So it's not practical for that purposes, and I don't feel like it really changes my management all that often. It can be used to monitor adherence for patients who are on bisphosphonates. So before treatment and during treatment, their markers should go down on treatment. So if there are questions about adherence, or that you suspect for the patient, then that might be helpful. And it can be helpful for deciding when to start patients back up on therapy who are on a drug holiday, but there's really no good, there's not a firm like guideline to help with that. So yeah, I think it's still an area of investigation of how we use these markers in clinical practice. Yeah. Mhm.
Thanks so much. Any last questions before we move on to our case?